MDM Belgium, and I'm also part of the European, the MDM network, international network, and I'm very happy to have you with us today. I greet also colleagues from the different MDM offices. This is an important moment for us because, as you know, MDM is present in 17 different countries. I guess 13 of them are in Europe, within Europe. And as you know, our mission is not only to provide care to people, and especially to people who don't have access to care, but also to be a witness, to testify, to make sure that we advocate for the cause of the people we're working with. And it's very important for us, this issue of access to healthcare. This is the core of the activities we're doing. We want to provide access to care to the most deprived people, but we also want to have the system providing access to care to them. And therefore, this report that we've been producing for quite a while now is very important. And we wanted to share with you the result of this report, and we were hoping that with the pandemic, we would have seen a bit of progress. But unfortunately, we're still dealing with people who are unheard, unseen, and untreated. And that's why it's very important for us to have you with us today to share with you this observation, this evidence that we are collecting, thanks to our collaborators, volunteers, and so on throughout Europe. We've been working in 7 different countries for this report. The report was available in the invitation to this webinar, so you can read it. But we will start, of course, with the presentation of it, and then we'll have a first panel. We wanted to have other people, sharing maybe not the same evidence with us of what they're seeing regarding this issue of access to healthcare within Europe. And then the second panel will be more oriented toward, okay, politically, what can we do? What has to be done? And that's how we've organized this morning. But first of all, we want to share with you, the heart of the activity, why we're doing what we're doing, with a little video that we coming from Belgium, and we'll have also a video at the end of the morning. But we can start now with the video. It's undertitled in French, but the translator will translate it in English as well. So can we launch the video now? If the sound is not working, it's undertitled, so you'll understand it. You can even give us money, so that's perfect. But we thought this testimony was interesting and important to introduce the debates, and so I won't wait more, but introduce Rachel Burns, who was the scientific person working on this report with us. She's from the UCL, University College London, and Pernilla Gravesen. Pernilla is the leading person within the MDM network on this report. So I leave the floor to them. They will make a presentation of the report through slides. For the questions, given the fact that we are very short on time with many people taking part in the panels, and also we want to give you the chance to ask questions. The question, please put them into the chat. We will manage, and we will have 20 minutes at the end of the morning to get the questions transmitted to the panelists. So floor is yours, Rachel and Pernilla, and thanks for all the work.
Thank you so much, Michelle. I will go first, and as Michelle said, I've been the project manager of the Observatory project, and I've managed this project for the past 3 years. So I'm very happy to be here today to talk to you about the report and its contribution to the data on unmet need for healthcare in Europe. I will also present the recommendations at the end of the session. So Rachel, if you give me the first slide, or Jan, sorry, give me the first slide, thank you. Okay, so the Observatory report is a product of the Observatory project. And this is a network joint initiative since 2019. And this project involves both data collection, it involves the production of a report, but also advocacy on the recommendations that we make in the report. This project, it's a project that allows MDM to bear witness to violations to human rights, and also to bear witness on barriers faced by our beneficiaries when they try to access healthcare. It is also a project that allows us to function as a platform for our beneficiaries to actually have their voices heard and put forward. The purpose of the report is to provide policymakers at both national level, but also at EU level, with the evidence base needed to continue the work towards universal healthcare coverage in Europe. So this report is basically an observational study of people excluded from mainstream healthcare in Europe. And it contains data and testimonies collected in 7 European countries within MDM domestic programs. And this data is collected in both our medical services, but also in our social services. So the data is both medical and social. And Rachel will go more into details about the analysis and the results of the data collection. Since this data is collected in domestic programs in European countries, it really provides a snapshot of access to care in European countries that have all dedicated themselves to ensuring healthcare for all through both the Covenant on Economic, Social and Cultural Rights, but also the Sustainable Development Goals. And they also pledges to reach first those who are furthest behind. So by presenting this data within the 2021 Observatory report, we can provide insight into who is excluded from healthcare, their social and economic and political circumstances, but also their health status. Next slide, please. Thank you. So there have been progress made in recent years to establish data collection on access to care in Europe. And this has been done through the introduction of the instrument called the Social Scoreboard. And the Social Scoreboard, it measures member state performance with regards to the articles in the social pillar. So for example, Article 16, that says that everyone has the right to timely access to affordable, preventive and curative healthcare of good quality. The statistics that are presented in this social scoreboard on the indicator self-reported unmet need for healthcare do not, however, include homeless people, people living in communal housing or institutional care, undocumented migrants, or children under 16 years of age. And a clear majority of the people that we see in MDM programs are in fact undocumented people, and also people that experiences different types of homelessness and insecure housing. So in order for informed decision-making to be possible, the magnitude and the specifics of the problem must, of course, first be known. And it is also imperative to reach the furthest behind first, to know who to reach and also how to reach them. So the MDM data is actually quite unique in this sense that we collect data on difficult to reach groups. And we are fortunate to enjoy a high level of trust with our beneficiaries, which gives us this opportunity to add to the existing EU data on unmet need for healthcare in Europe. So we can actually provide a complementary view to the data already existing. I'm going to stop here and hand over to you, Rachel, to further present the data.
Thank you, Pernilla. Jan, next slide, please. Thank you. Briefly, I'm Rachel Burns, a research fellow in inclusion and migration health at the University College London. And I had the opportunity and privilege to conduct the data analysis for this year's Observatory report and look forward to reviewing the main findings with you now. So between January 2019 and December 2020, more than 25,000 individuals attended 6 MDM programs in Belgium, France, Germany, Luxembourg, Sweden, and the United Kingdom. A total of 45,000 consultations were held with an equal mix of both social and medical. So in the figure here, blue shows the number of individuals attending an MDM program in 2019 and in white 2020. You can really see the dramatic reduction in numbers from 2019 to 2020 in both France and the United Kingdom. And this is as a result of as you can imagine, the pandemic and a reduction in services impacting the total number of service users they could see. There was less of an impact in Belgium, Germany, and Luxembourg, and Sweden. In total, around 60% of the people seen in these 2 years were men and about 40% women. The median age was 34 and 1 in 10 was under the age of 18. Next slide, please. So here is a map showing the geographic spread of nationalities or countries of origin of MDM service users. The darker the blue represents more individuals from that country. A total of 158 different nationalities were recorded, and the top 5 countries were Côte d'Ivoire with almost 11%, Romania at 10%, Bulgaria at 6%, along with Morocco and Algeria. And you can see the kind of clustering of dark blue in the eastern part of the continent of Africa. So about more than half of our individuals at MDM program seen were countries of origin from the continent of Africa. Next slide, please. So we use migration status as a way of categorizing the different types of migrants that are seen in MDM programs. So that is defined as non-EU migrants, EU, EEA migrants, and nationals. Here, this figure shows the distribution of migration status by each MDM country. So in total, around 3/4 of service users were non-EU migrants, about 1/5 were EU, EEA migrants, and about 3% were nationals. Luxembourg and Germany had the highest proportion of EU migrants and nationals, while the UK, as you can see here, had almost all of its service users were non-EU migrants. The highest proportion of non-EU migrants was in the 30 to 34 age group. The highest levels of EU migrants were actually observed in children compared to other groups, as well as almost 1/3 of all nationals who attended an MDM program were under the age of 4. Next slide, please. So in addition to migration status, we also look at immigration status as defined by the service user themselves. This figure here shows 4 immigration statuses: EU, EEA migrants without permission to reside, non-EU, EEA migrants without permission to reside, a visa or permit, an individual who does in fact have permission to reside, and that could be in the form of visa or permit, and someone who is unable to find. So EU, EEA migrants without permission to reside are those who are residing in their host country for over 3 months, but not fulfilling the requirements of the EU Directive 2004/38 EC, meaning that they were either not employed or self-employed and did not have sufficient resources for themselves or no health insurance. All of the countries that were included in the report, about 2/3 of the individuals were non-EU migrants without permission to reside, and about 1/3 had permission to reside. In Germany, we see the highest number of EU migrants without permission to reside, about 1 in 3. Highest numbers of non-EU migrants without permission to reside were in Belgium, France, and the UK. Next slide, please. So the report also looks at a number of determinants of health, including housing status and poverty. Across all countries, a majority of people were living below the poverty line. And this can really be seen in the types of housing in which our service users are living. So to define housing status, we use the ethos categories, and this is the European typology of homelessness and housing exclusion categories. And these include personal flat or house, inadequate housing, so unfit or overcrowded, insecure housing, so this is living with family and friends or without any form of secure tenancy, houselessness, so living in some form of temporary accommodation, and rooflessness, so living on the street or perhaps in emergency shelters. So here in this figure, we're looking at housing status by migration status. So EU migrants had the largest proportion of rooflessness, while nationals had the highest proportion of houselessness. Non-EU migrants mostly lived in insecure housing. Almost half of the individuals in all MDM programs lived in insecure housing, while 1 in 5 were roofless or sleeping rough. Luxembourg and Germany had the highest proportion of individuals experiencing houselessness and rooflessness. Next slide, please. So here we're showing self-assessed healthcare coverage. So again, this is defined by the service user. So in all countries, a majority of people reported not having healthcare coverage. Belgium had the highest proportion of people reporting of not having healthcare coverage at 86%, while Sweden and Luxembourg had the highest proportions of individuals reporting full healthcare coverage at 19% and 15% respectively. These numbers lead nicely into the next slide, which is about barriers to healthcare. And a large barrier is the lack of knowledge of the healthcare system and entitlements. And this can really be seen here in the UK's bar, with 78% of people saying that they don't have access to care, when in fact all people, regardless of immigration status, are entitled to primary care. Next slide, please. So barriers to healthcare. When presenting an MDM program, people are asked about barriers they face about accessing healthcare. So this question allows for multiple responses as well. So here we can see a total response across the 6 countries. So 1 in 4 people said that a barrier was lack of knowledge of the health system or entitlement or administrative barriers. And looking by country, about 64% of those who did not try to access healthcare came from the United Kingdom. About half of the responses for language barriers were people from France, and about 35% were people living in Germany. And about 63% of responses within the economic barriers came from France. So this really shows how, depending upon the composition of the population and where they are, different barriers come up. And that, that has to also do with the diversity of health systems in Europe. Next slide, please. So the main type of kind of pathologies that were seen in the clinic are about 1 in 5 people had some form of disease of circulatory system, along with tons of other categories. The kind of higher ones were respiratory, disease of the respiratory system, or the musculoskeletal system and connective tissue. People also come to MDMs looking for maternity care, and about half of the pregnant people had not previously attended an antenatal appointment prior to coming to MDM. And of those, around half of them had not accessed antenatal care, and they were in their second or third trimester of pregnancy. In the past year, some MDM programs have started to do a patient health questionnaire too, as a pre-screening for major depressive disorder. Of those that responded to both questions, 1/3 had a score greater than 3 and should be screened for major depressive disorder. Next slide, please. So kind of in conclusion, I think I wanted to, it's not a limitation, but I think it's something that I felt needed to be said, is that this report uses operational data, which in some ways, allows us to capture a large population of people experiencing health and social exclusion in Europe that wouldn't necessarily be captured in national statistics. But as a result of the nature of the data, this does result in some numbers that reflect differences in potential service provision. So was a country on a mobile van more? So are they, that might impact the composition of those populations in which they serve. So within the report, we tried to comment on those, as well as some variables have larger amounts of missing data. And this has been commented and reflected on in the report. And some numbers should be kind of interpreted with warning due to that. This report really reaffirms the utmost imperative for the need to capture and evidence health inequalities if we are going to achieve universal health coverage in Europe. Thank you so much. And Pernilla, I'll leave to you for the recommendations.
Thank you, Rachel. Yes, as we said earlier in the beginning, the purpose of this report is to provide policymakers at both national and EU level with the evidence base needed to continue the work towards realizing universal healthcare coverage in Europe. And to aid in that sense, we also provided recommendations at the end of the report, which are based on the evidence that we found. So we make recommendations within 4 areas. And the first set of recommendations are around issuing better data. And as mentioned before, the unmet healthcare needs described within this report are not represented in official reporting. So the importance to know who is excluded from healthcare obviously became even more evident with the COVID-19 pandemic and the vaccine programs. And both national governments and EU institution therefore needs to ensure that the monitoring systems that do exist need to provide the relevant information by including, and they can do this by including service users, civil society organizations, as well as the affected communities when you develop methods for data collection, but also for data analysis. The second set of recommendations we make around the reviewing of laws. And through international covenants, the right to healthcare is binding in all of the countries that were represented in this report. However, national laws sometimes restrict access, and this is especially true for undocumented migrants, asylum seekers, and mobile EU citizens. For example, undocumented migrants do not have access to healthcare in some countries because their data is shared with immigration authorities when they seek healthcare. This means that they are avoiding to accessing healthcare due to fear of expulsion. So these laws should be systematically reported and they should be reviewed. And for example, this could be done by ensuring firewalls between those working with provision of healthcare and immigration authorities. The third set of recommendations are around making healthcare systems more accessible. And it is very clear from the evidence in the report that it is not only restrictive laws and policies that make access to healthcare harder for certain groups. And the barriers most frequently mentioned were lack of knowledge of the healthcare system, administrative barriers, economic barriers, and that was also mentioned in the video that we saw in the beginning, but it can also be language barriers. So an important pillar in the provision of healthcare is to ensure that it is in fact available, accessible, acceptable, and of high quality. So we therefore encourage national governments to reduce barriers by, for example, providing comprehensible and targeted information on services and entitlements to migrants and to homeless people experiencing homelessness. And to the EU Commission, they should make sure that financial instruments such as the European Social Fund Plus is available to fund initiatives that respond to this unmet healthcare needs of those who have been excluded from healthcare. Finally, we also know that the conditions under which we live and grow will determine our health to a higher degree than our ability to access healthcare services. And homelessness, we also know, is a major determinant of health. I think, if I remember correctly, it was only about 17% of the people that we saw that actually lived in adequate housing. So a great majority experience different kinds of homelessness. We therefore encourage national governments to make sure that there is a legal base for the right to housing and to implement preventive measures against homelessness. And this was a very brief description of the recommendations that we made. And of course, they are all available in the report. So if you have any more questions on that later, you can also email me, but please make sure to check the recommendations in the report. Thank you very much for your time. And I will hand back to you, Michelle.
Thank you, Rachel and Pernilla. Pernilla, you could put your email address in the chat for people, and Rachel too, of course, if people have any questions.
For sure.
Okay, thank you so much. It's kind of setting the scene. Now we want to have testimonies and contribution from other actors working also with the public we're working with. And I'm very happy to have Rob Aldrich, University College London, Professor of Public Health Data Science, to facilitate the first panel. And I leave the floor to him. Welcome, Rob, and thank you so much for helping us with the first panel.
Thanks very much for the invite. It's fantastic to be joining you today and to have this opportunity to discuss the results. So I'm going to be joined in this next session by 4 excellent panelists to really kind of bring to life some of the findings and also explore in their experiences what some of the further challenges are. We've got about 45 minutes, I think, and I'm going to go to each of the panelists in turn and then kind of bring everyone back together. So it's my delight to first of all introduce to you Dr. Bernadette Kumar, who is chair of the European chapter of the Lancet Migration and president of the European Public Health Association section for migration and ethnic minority health. I know Bernadette very well, so I'm hoping this can be more of a conversation, particularly I think we're about to talk about some of the things that we've talked about a lot in the past, Bernadette. So I think it's obvious to me that this report is really important in terms of describing the real severe unmet needs that are seen by these people across Europe and the healthcare systems that are excluding them. And I think it's been made by Rachel and Pernilla, the point that existing systems do not capture these people. Something that we've talked about in the past a lot is how do we really do research that can better highlight this issue and make it policy and decision makers more accountable on this topic? What do you think we need to do going forward?
Thank you, Rob, for that question. And it's good to see all of you. And first of all, I'd like to start off by commending MDM and all the colleagues who worked on this very important report, because I think this report is exactly to answer the question very simply what we need in the future that uncovers some of the data that we don't see. The issue that we have to look at is how we can change both the production of the data that is happening at the moment, and also it has to be very much user driven. And here I'm not talking about users as in migrants, but I'm talking about policy makers, because often research is left to the realm of researchers, and I'm not trying to, in any way, I'm a researcher myself, and it should be also policy maker driven. But the policymakers have not actually wanted to have a lot of this data. And the reason is, if there is data, it means you have to do something with it. So therefore, there is this impasse that is there. And researchers are, as researchers should be, interested in things that they drive. And so it becomes very selective. And there's a lot of data, and we've seen in the last 20 years or so, the data on migrant health has just surged, but there are still critical gaps. And this MDM report is an example of that critical gap. So I think that we have to get policymakers to be asking the questions. And once they ask the questions, then the data will come forth on that. Also, what is a big challenge for us today is the fact that data on migrant health is very ad hoc. It's not part of routine systems. The data is again done whenever somebody gets a grant. It's again left very much to the research community, and the research community is already starved for funds, as we know, and therefore again we have a problem. And therefore funding agencies also have to look and prioritize this as an area, and not say, okay, it's going to fall into a large thing. So again, I think that the issues are very much related to what we're able to research on, and many of these important topics get left out. So you have policymakers, you have funding organizations, you have also then the providers of health, and the providers of health do have data, but again the providers of health use the sort of classical approach, in which is migrant status is not mentioned. And just the last thing I'm going to say, because otherwise I could keep talking, Rob, until the cows come home. But it's about actually looking at a couple of things that we've seen in the past. And what we've really seen in the past is that countries are at different levels when it comes to research. And I think that is also a very big problem in Europe. So rather than expecting people to immediately produce masses of data, we need to take it in turn. I'll stop there.
Fantastic. You've touched on so many different things there, and some really challenging issues as well. I think just to dig a little bit more on one of the points and make it specific to universal healthcare coverage, I think I wholeheartedly agree with you that it has to be driven by the need from policymakers if it really is going to make a difference. How can we achieve that, particularly within universal healthcare coverage? What is the role of researchers to kind of generate that need from policymakers so that we can achieve universal healthcare coverage? Because as this report shows, we clearly are not achieving that. So how can we tackle that issue to get policymakers to want this data and then to use it to meet that gap?
Okay, I think that what we have to do, we really need advocacy on this particular area. And I think that that's what the MDM report can be used, because often what happens, and this is again a classic symptom, and no offense meant to any of the researchers, we're very happy when our research is published and we think that's the end of the story. And just like we've seen that the migrants don't know about the healthcare system, the policymakers have no idea what we've published. They're not following all our publications. So I think the dissemination and advocacy part of it really needs to be strengthened. If we're going to go and say to them, we don't have this data, and we have to explain why we don't have the data. And a lot of our data in the past, we do have data now that describes the situation. So if you look at the data that we've had, with the Commission report and a lot of reports that have come up, the WHO report, it tells us the situation on the ground, but it doesn't tell us the why, and definitely not the how. And what the policymakers are also interested in is exactly that, the why and the how, because that's what their policies can change. And so we need to also again, look at the type of data that is being produced. So that's why I would say that we definitely need more advocacy. We need dialogue. We need arenas that we can have dialogue with the policymakers, with the funding organizations, and with, of course, the migrants themselves, who are able to tell their story much better than any of our numbers will.
Fantastic. Thanks very much, Bernadette. I'm going to come back probably at the end for one last question once we've gone through a couple more. But thank you for that really wide-ranging and important, and I agree with everything you've said, and hope to be more of an advocate researcher than I already am. So I'm now going to move on to Dr. Klaas Itterbrink Nordenskjöld. Apologies if I've not got your name pronounced correctly there. Who is the physician in charge of domestic operations in MDM Sweden. I'm really interested, as I think as Rachel's and Pernilla have described, the individuals, the people who are lacking access to healthcare in Europe, their issues are multifaceted, and the barriers that they encounter are also, multifaceted. So as a healthcare professional, as a volunteer at MDM, and as a researcher, what kind of unmet need do you observe in your work? And what could the long-term effects of this be on an individual's health?
Thank you. Research shows that vulnerable populations, such as the patients we meet, undocumented migrants and European citizens without health insurance, have increased risk of a wide range of diseases and premature death. And what could the mechanism behind this be? The simple answer that I see is that this is what happens if you leave one part of the population with a partial or complete lack of medical attention. So my research shows that the basic panorama of diagnosis among our patients at MDM and the Swedish patients overall are in large the same. They face uncomplicated problems like infections, troubles of the musculoskeletal systems, pains that most of us suffer from time to time. And these diagnoses are troublesome, but they are very seldom deadly or severe. But exactly like the general populations, our patients also have a high degree of chronic non-communicable diseases such as hypertension and diabetes in need of regular medical attention so as not to cause serious complications. And when these conditions are left untreated, our patients die in advance because of heart attacks, heart failure, stroke, and other preventable or delayable complications. And this list of complications and diseases causing suffering and death could be continued. There are several research articles, each giving one part of the explanation to the health problems of vulnerable populations. But I think for today, I will stop here.
Fantastic. Thank you very much. I think one of the things I've been involved in this report for a few years now, and it was one of the things that really shocked me in the first year that I was involved, and it's still obvious in the data now. And that's that in the NDM clinics, we see a lot of European citizens who clearly have no access to healthcare across not just one country, but across all the countries in the reports. And I find that extraordinary. I find that, something that is shameful, basically. Could you maybe, there might be people on the call who this is the first time they've encountered this, but I think it would be great to hear from you and, on your frontline experience, if you could describe the kind of barriers that prevent them from acquiring care and the sort of issues that you face as a healthcare provider and professional trying to ensure that access, particularly in the Swedish context.
Yeah, so European citizens need the European health insurance card to be able to seek subsidized care when leaving their country of residence. And our patients at the MDM face a set of obstacles when trying to get hold of this card. It's discrimination, for example, need for literacy, need for employment, need for money. There are several difficulties that can arise. Roma people are especially affected by this, and people not yet fully citizens, but with temporary permits or working permits moving within the union, not fulfilling every requirement of, for example, employment or citizenship. And these groups are generally economically poor, living under vulnerable conditions, as we saw in the report, and with a high risk for many diseases. And without the insurance card, they cannot access subsidized care. In Sweden, for example, this means that a European citizen making €5 a day on begging needs to pay €200 for a doctor's appointment. And this is not including investigative measures or follow-up or anything. And this means that even though this citizen is not prohibited from seeking care, it's very effectively hindered. So when the vulnerable citizen comes to the health center asking for an appointment, the staff is faced with sort of a dilemma. Either they offer an appointment, giving the patient access to healthcare, which she will not be able to pay, but fulfilling the human rights of that person. Or they will do what is right according to the rules of the local unit and according to national law, and ask for the unsubsidized fee in advance. And if the patient cannot pay, she is rejected. And from my experience, most people are actually more interested in following the local rules than doing what is right according to international rights. So as long as the rules of the units and the national law is unjust, the healthcare will continue to be unjust. And to just further explain how I see this, I can just say that you can almost see the discrimination, the weight of discrimination on these patients' shoulders, in their aged skin and aching joints. Not being able to go to the doctor when one is ill is such a great stressor that it, from my experience, in itself can harm one's health. Thanks.
Thank you. It's really powerful to hear that description, and I agree that with my clinical experience, you can literally see it physically manifested in these patients. I agree. I wanted to just sorry, I know this is not a pre-prepared question, so but I think it's interesting. We face these dilemmas as clinicians in the UK as well, where we're deciding about the status of an individual and what to do in that clinical encounter. Is there a role for kind of a clinician advocacy there, that the sort of thing that Bernadette was talking about? Because I think in the UK we've seen various movements like Patients Not Passports and doctors refusing to ask about immigration status. Do you think we can do more amongst ourselves as clinicians with working in National Health Services on that point?
Most definitely, yes. I think we can speak to the personnel at our units where we work. We can speak to our bosses. We can educate our colleagues and demand the right for these people. We can actually meet them in the waiting room and speak to the receptionists. We could develop projects where people not suffering from discrimination follows the patients to the clinics to ask for healthcare, to stand up for their rights.
Thanks very much. It's really important to hear your perspective on this. Thank you, and I'll come back at the end. So our next panelist is Simona Nicoleta Barbu, who is the policy officer at the European Federation of National Organisations Working with Homeless, FIANSA. So this is a topic very close to my heart. I've done, and I think the data that we saw throughout the reports is again another really shocking testimony about what's happening in Europe. And we've seen in the report this time that almost half of the people in MDM programs between 2019 and 2020 lived in insecure housing, many of them being roofless. And we know that EU statistics often exclude people experiencing homelessness, and we certainly see that in the UK context. So Simona, could you reflect on the consequences of this lack of data in the EU and the fulfillment and its relation to the fulfillment in relation to the rights around housing and health? Oh, I'm not sure we can hear you.
This. Can you hear me now?
Just about, yeah.
Oh, sorry.
Yeah, that's better. That's better.
Yeah. So thank you so much for the invitation, and very honored to be here today and to have worked in the past with Pernilla and MDM on previous reports, previous versions of the Observatory report. For us, it's also a very important topic at FIANSA, and speaking of data and of how this brings consequences the lack of data brings consequences to people's lives and the fulfillment of the rights they have. I think that the presentations here today are a direct and very clear image of those consequences, that people are being held in situations where they're underserved, they do not have access to basic needs. Many come from very poor backgrounds, like it was mentioned earlier. We also work a lot on mobile EU citizens, and myself being from Romania, I know how the system works and how people are being denied this kind of help. So as long as we will not have data in place to show what are their needs and how do we tackle the needs and the barriers that people face, we will not be able to move forward. It just means that people will be held in exclusion even further, and it also means that the policies will not be suitable. They will not be tailored to support people in achieving their rights. It's as mentioned in the report, I think it also means that it will prevent, not having data, it will prevent the main stakeholders to coordinate and to set in place and to take informed decisions. So it will just mean that we're not able to advance. And to a more general overview, I think not having data, it also contributes to a lack of awareness in general society. As it has been said, advocacy is so important, but if we do not know what people are facing and where do they come from, society will continue to function on the stereotypes that exist, and seeing people experiencing homelessness hard to reach, and then homelessness as a lifestyle and a choice. So we won't be able to move on.
I agree so much. Simona, I wondered if we could just touch on one additional thing, and particularly Fianza's perspective. So we've obviously been in a pandemic for the last 2 years, and the data in the report captures some of that period. But I'd just kind of like to bring in some of your experience in particular in relation to this, because obviously within the pandemic period, governments and public health measures have been recommending things like social distancing, hand hygiene routines, isolation at home, which is obviously, if you live in insecure accommodation or roofless, this is not feasible and not possible. These require adequate housing. So can you tell us from Fianza's perspective what the effects of the pandemic have been for people experiencing homelessness across Europe?
Definitely. I think that the pandemic has affected people in homelessness on so many levels, and it has further deepened their exclusion. But I can leave in the chat some links to our publications that you probably know and have been involved in as well. But just to mention main issues that we have seen, of course, it was very straightforward that for people experiencing homelessness, it was not possible to apply prevention measures and to comply with public health guidelines, which made it difficult for their everyday life on different levels. It meant that they could not protect themselves from the disease. People who lived in communal dormitories didn't have the possibility to isolate socially. But then it also brought consequences such as people receiving fines for being outside on the street after the curfew. And it is very difficult to comprehend this kind of measures, but they did happen in several member states. A big impact that we have seen on people experiencing homelessness has also been their mental health and how it was affected. Apart from the fact that people could not understand in the beginning what happened, and there was a shock, an initial reaction of shock to see that nobody was on the streets, to see that they couldn't make the small income that they could get from activities like begging and or selling magazines, which are also very common among the beneficiaries of the MDM services, as it was said. But then moving forward, it was very difficult for people. They experienced loneliness, they experienced even more stigmatization. It was said by some of our members that especially migrants, asylum seekers, they had a very hard time in this period to maintain social relationships, which meant a lot for people who were already very excluded from societies. And then I think that there were also reports of basic rights, such as the right to food and water. Many of the taps were closed in cities. People didn't have the possibility to access even drinking water. Yeah, I think I could go on, but maybe
yeah, I think the fact that the fact that you could go on just as testimony to how bad it's been over the last 2 years for this group. I just wanted to ask one quick question to just to get if your experience in your European overview about, do we have a sense of how well or not we're doing in terms of providing a vaccination for people on the move, and in this group in particular? Have we got a group that is still remaining very vulnerable? My suspicion is yes, but do you have any data or any kind of evidence that we can use in our advocacy work for that?
I would have to check the latest data on vaccination uptake, but I know that there was a lot of work did, and including us at FANSA, we advocated for including people in homelessness on the priority groups for vaccination. And this has been done to a certain level in many countries. They acknowledged and realized very soon that people in homelessness were one of the groups who needed most the vaccines. However, there are still barriers. There is vaccine hesitancy, as it happens with everyone. So I couldn't say right now, but I will have to check and get back to you with that. Yeah.
Yeah, thanks. That would be great. Thank you so much. So going to move on to our last panelist now, Michelle Levoy, who's Director for the Platform for International Cooperation of Undocumented Migrants, PICUM. Welcome, Michelle. Carrying on from the last question on the pandemic, I was wondering if you could reflect on the lessons learned as well as ongoing challenges from the pandemic in terms of the response for undocumented migrants across Europe.
Thank you, Rob, and thank you so much for the invitation. It's great to be able to participate. PICUM has some members who are MDM networks, and Nathalie Simano was one of our board members for many years, so great to see her on the call as well. I think in terms of the pandemic, in terms of what we actually as PICUM were working on, especially last year, was access to the COVID-19 vaccine for undocumented migrants. We started actually last year by mapping it and then putting a lot of that work on social media, and that's actually kind of gathered a whole momentum, and a lot of mainstream media outlets then were looking into it, as well as some investigative journalism bodies. And the one I wanted to highlight here was Lighthouse Reports, which published a policy scorecard in November of last year, where it looked at 18 countries' policies. So not necessarily the practice, but really the policies concerning the COVID-19 vaccine. So in that investigative journalism work, they found that despite a number of very inclusive practices, Portugal was mentioned, for example, in terms of its policy, the UK as well, despite the hostile environment, they actually found that, so despite a lot of this, many of the policies themselves were still a bit vague. They were open to interpretation. And also there was the important regional differences in countries where healthcare is managed regionally. We actually saw some interesting national level developments. Norway published, its public health directorate published guidance on the COVID-19 related care for undocumented migrants. And it's addressed a letter to local and regional authorities, urging them to make the vaccines available to everyone. Faced with a lot of these administrative obstacles to registering for the vaccine, authorities in cities and NGOs in Bergen and Oslo took a lot of practical steps to ensure access. And Greece also adopted a national law, as well as some interministerial decisions that would grant access to the vaccines for undocumented. But I think the bigger question that we're kind of posing within the PICOM network, and I can imagine many of us who have worked also on the COVID-19 vaccine and on undocumented, are kind of, where have these developments gone to? What are they leading to? What are some of the broader lessons going forward? Before the COVID-19 vaccine was an issue in Europe, and as we know from the MDM reports, there still is this challenge of access to healthcare for undocumented. I actually did want to highlight some developments, though, that have been happening now on the global level, which might offer some hope. Sorry. The World Health Organization, WHO, met last week in Istanbul with nearly 40 ministers of health from the Europe region, as well as from the Middle East and Africa. It's great actually to see Santino Severini from the WHO on the call today. And the reason why I wanted to mention this is because they adopted at the end of the conference an outcome statement. And the first pillar of this draft outcomes, of the outcome statements, says that member states need to strengthen the provision of universal health coverage regardless of migration status. And it's really important that this regardless of migration status is here, because this outcome statement will help the WHO in developing its new multi-annual action plan on migration and health, which will be ending this year. And there's also two other developments that I think are useful for us to bear in mind, also in relation to advocacy in general. The UN Secretary General released his report in February this year. The report dates, though, from December 2021, on the implementation of the Global Compact on Migration. And in paragraph 98, the Secretary General also calls for enabling migrants to access health service, regardless of migration status, in line with the principles of universal healthcare coverage. And then the other very ongoing development is the International Migration Review Forum, it's called the IMRF, will take place in May in New York, and governments will review the progress that they've made towards implementing the Global Compact on Migration. So there's two countries, Luxembourg and Bangladesh, who are the co-facilitators for that process. They just released last week their zero draft, so their document that member states will now negotiate. And in that zero draft, there's also many references to enabling access to service for migrants regardless of status. So I just wanted to kind of highlight some of these as well, because I think they are also hooks that we can also build on in terms of some of the advances also made on the COVID-19 vaccine, for example, for undocumented, and some other advances.
Thanks very much. It's great to hear about those opportunities. And I think kind of you mentioned the advocacy role, and I'm kind of going to tie us back to Bernadette's call at the beginning. Because I think what we see in this report and what we see in all of our work is this intersecting barriers that, you know, an individual doesn't tend to have one. Rarely is it one particular exclusion factor. There's multiple, and this requires us to work across different advocacy sectors and different research groups. And how do you think we could join up our work and our advocacy? And I guess, like, if you've got some points that you could make about how researchers in particular could do this advocacy bit better.
Yes, thank you. It's interesting to reflect on this because PICOM actually has just commemorated 20 years of existence. And if we kind of look back over 2 decades on all the themes that we work on, so healthcare was the first theme that we started to work on. It's been kind of a constant theme across our existence, but we also work on labor, on children, on justice, on detention, etc. So of all of these themes, I would say that some of the most progressive developments that we've seen concerning undocumented migrants' human rights has been in the area of healthcare. And the reason why has been because there has been close cooperation between civil society organizations, NGOs, health professionals, researchers, human rights institutions, local authorities, health ministries, UN entities. I mean, it's been amazing actually to see it. I just say this because I think we all heard the findings from the report. We know the urgency to work on, but we also have to realize that there have been really, really important advances that have been made, despite their own shortcomings, these important advances. So I think one of the first ones that I wanted to highlight is Sweden. Sweden's legislative change in 2013 to broaden the healthcare for undocumented to basically make it equal to the healthcare that asylum seekers have. It's still relatively narrow. We're very aware of that. And as Klaus and others would say, there are challenges on the ground even to implement that. But it took more than 15 years basically to get the law to change. And it only changed because of all of that cooperation. I mean, I think the Right to Health campaign in Sweden had more than 80 participants or members, including all the major trade unions by the time it was kind of rolling around, you know, rolling onward and trying to influence the government. There was a parliamentary report. There was a visit from the UN Special Rapporteur on Health. So there were so many different moments, but it was also quite long that it took to really change that. So I think patience, persistence, endurance, they're all kind of keywords, I guess, that unfortunately we have to use to describe a lot of this advocacy. But I also think it's good to also think, what are we advocating for? So our first recommendation is always mirroring what was in the presentation at the beginning. So analyze the legislation. Is the legislation at fault? In Sweden, it definitely was. In Germany, it still is, concerning paragraph 87 of the Residence Act. And that's the second example I wanted to make, is that German civil society have also been advocating for years to try to change that paragraph, which requires health professionals to report undocumented migrants to the immigration authorities. So that means that on paper, they in theory have the access, but in practice, not really. And it just reinforces this whole culture of fear. And after a number of years of advocating and also bringing on civil society from the privacy and the data protection organizations, they managed to get the new coalition agreement to agree in December of last year in its agreement to change that paragraph. So that's a huge step forward, because that's been something civil society in Germany has been trying to challenge for years. So it's the legislation, but it's also the firewalls. So the paragraph 87 is an example of that. But the advocacy is also around this delivery of healthcare. So it's, you know, the law has to be there, the parameters have to be there, the firewall has to be there. But then even when you have all that, sometimes it's still not enough, because I think many of the Médecins du Monde, or the Doctors of the World entities, see that the reason why you see so many people is because their needs are so complex. And even having the mainstream access, navigating that with all those barriers that were talked about earlier, sometimes they're just insurmountable. So that's why there is the need. So the delivery of the healthcare is really strong to look at what are the other needs besides the actual, you know, what are the interconnecting social needs. I think here we've seen some interesting initiatives. The city initiative on irregular migrants, which is coordinated by Compass at the University of Oxford, produced guidance in 2019, where it looked at 11 cities' experiences, policies, and practices, including in the area of healthcare. And I would say, and PICUM is a member of the initiative, and we've seen that there's a lot of close partnership that does exist between cities that have progressive agendas, also including healthcare for undocumented, that work closely with civil society. And the last one I want to briefly mention is the Nobody Left Outside initiative that FEANSA is also part of. It's called NLO. And this actually brings together a lot of organizations and EU networks that look at some of the most marginalized communities in Europe. And we kind of collectively then advocate towards the EU institutions for better integrated care that looks across social issues, housing, etc. So I think that there's many different, our own experience within PICUM is that when you're looking at marginalized groups and undocumented in particular, no one is ever able to do it alone. Any researcher, any NGO, any local authority, it's always primordial and essential to have partnership and cooperation. And it's very long sometimes and very painful, but it's possible.
Yeah, thank you very much for reminding us of that. And I think it's great to have that historical perspective and to kind of highlight some of the progress, despite, it seems like such an extreme situation right now. The fact that there has been that progress is important. So I'm going to, in the last 5 minutes, I'm going to ask you all the same question, if that's okay. So I'll go back, starting with Bernadette. As the report highlights, we haven't achieved universal healthcare access in Europe, and the people that MDM sees highlight that. So what can I ask each of you in this last 5 minutes, just to briefly think or outline what you think are the key opportunities and barriers to achieving universal healthcare by 2030? Bernadette.
Okay. Basically, we need the whole day, but I'm going to try and
in 1 minute,
shorten in 1 minute and say that what we need to do is not just look at the formal barriers, because we always get very stuck with the administrative, the legal, the legislative, and as Michelle just pointed out, it might take 15 years and we don't have 15 years to wait. So I think that what we have to do is two things. One is look at the non-formal barriers, which are very much related to issues related to language, to accessing information, which this report pointed out as well, and work on those parallel to getting the systems changed. So I think that's what I would say, that's why we really need to start with. And if we start with that, then we can make small steps and achievements.
Fantastic, thank you. Dr. Klaas.
Yeah, so my focus would be national legislation, since I think, I mean, the informal barriers are super important as well, but some of the informal barriers are kind of a result, I think, of the more formal barriers, such as lack of legislation. And I think all working groups in the healthcare system are affected by the lack of legislation, from the receptionist, which is like a gatekeeper, but also the very prestigious physicians sitting in the hospitals. I see them also making not medical decisions when an undocumented migrant shows up, but they go to making decisions based on ideas about this person's right to stay in the country. So from my perspective, I really like to focus my work on using the democratic system, my democratic right to speak up to those in charge and demand change of national law.
Thank you very much. It's good to hear the contrasting perspectives. Simona.
Thank you. Yes, I think agreed with everything it was said. And from our point of view at FANSA, a first thing that we have to address is this gap that exists that keeps people excluded. It's very much related to what Bernadette was explaining, these non-formal challenges and barriers, but we need to look at what is keeping people from accessing primary healthcare. And we have very good practices from our members who work with making healthcare more inclusive, bringing in peer workers to support training for health practitioners and to advocate themselves based on their previous experiences of homelessness on the right to health and for addressing inequalities. Thank you.
Thank you very much. And finally, Michelle.
Yeah.
You've already given us a great deal, but I think just to conclude.
I would maybe just say, let's not lose the momentum. I would keep momentum as a key word. We actually see from our perspective, looking at the EU level, looking at the global level, that there is actually a good momentum now, relatively speaking, where there's some more openness to talking about undocumented migrants. The European Commission just put forth its proposal for legislation on gender-based violence, I think it was 2 weeks ago, where they actually, in their proposal, now this is still a legislative proposal that has to be negotiated by the Parliament and the Council, but they do call for access to victims of gender-based violence to shelters, regardless of migration status. So this is a promising advance. We also have the victims of crime strategy, which also looks specifically at enabling victims of crime. This is also from an EU strategy to get access to support and services, also including healthcare. So there is some more momentum in looking at kind of the fuller picture concerning undocumented migrants' human rights. I would also add that another area that we also need to look at is migration policy itself, and the impact that the very lack of a progressive migration policy has on migrants' human rights, and to also take that angle. WHO itself is actually looking at detention, migration detention, and health now. They're doing an upcoming report. So I think these are all angles that we have to explore, and at the same time realize that because health in the EU is still a national level competence, it still is national level legislation. But I would also add that part of the momentum is the cities, the local authorities. I also saw Natalie's comment in the chat of trying to change practices as a way to show that it's possible to do this so that you can also then change policies. City level authorities are also clear partners on all this. So I would just maybe let's kind of try to, despite all the difficulties that I know are very, very clear to everyone working in this area, let's try to keep up some kind of a momentum.
Thanks very much. I think that's a great note to end this panel on. Thank you all for bringing your really diverse and important perspectives to this. It's been really fascinating for me. I've learned lots, and I'm looking forward to becoming an even greater advocacy researcher and take up Bernadette's challenge to me. Thanks very much. I'll hand back to the chair.
Thank you so much, Rob, and thank you so much to the panelists. It was super interesting, really. Talking about momentum, it's very impressive. And I guess it's not only in Belgium to see the discrimination being made between Ukrainians, refugees. And of course, we're quite happy with, having them with us and trying to welcome them as much as good as possible. But at the same time, the rest of the migrants are still quite discriminated, also in access to health. Once the Ukrainian refugees are registered, they just have automatic access to health. Well, there were so many people having been in Belgium for months and years, and that's still not having access to health. So if it's also part of the momentum mission, I would say, I guess. Thank you so much. The momentum for us now is to have tea or pause. 5 minutes pause, and we're waiting for you to get back here around 2025 to start with the second panel. Thank you so much, guys. Don't leave us, stay with us, and come back within 10 minutes after a good tea. Thank you. Hello, everybody. Hope you had a good break. So we are for a second panel. Even if we had already very nice and interesting recommendations to act and to combine our research and the work we do out on the field and so forth. Now we're going to more focus on political recommendations, and I will leave the floor to Caroline Coston. Caroline has been busy for quite a long time in public health issue, and she is director of EuroHealthNet, and has been, as I said, busy with public health and health promotion for quite a while. So thank you so much, Caroline. I know you're very busy to have accepted to facilitate this panel, and I'll leave you the floor.
Thanks a lot, Michel. I'm delighted to be here. And indeed, I'm busy, but I think we are all very busy. So it's great to see everyone here in this webinar, and also the speakers of my panel. Maybe for some of you who do not know EuroHealthNet, so we are a European partnership of mainly national public health institutes, some regional health authorities, but also some ministries of health that are all concerned about health inequalities and the need to reduce them. So therefore, this report is a very important one and a very timely one, and we are delighted to have this report. It is an important report, I think, that complements two flagship reports, one of the Commission on the state of health in the EU that was published last year, and another flagship report from the WHO Euro on health information, so the health information report. And I find it a bit sad in a way that these two mainstream reports are not sufficiently taking on board all the information that you have revealed in your report. And part of our advocacy needs to be directed to these big institutions to make sure that they capture all of this information also in their report, and use different methodologies and work with organizations like MDM and other organizations to make visible what is still invisible, as that is so important, as we have also heard in the first panel. Anyway, so with this panel, we are going to look into actions from local to European and global levels. And I'm delighted to have excellent speakers in my panel. And I would actually like to start with the local level, the regional level. So I hope that our colleague from Spain is here. And I'm delighted to give the floor to Carlos Artundo. He's the Regional Director of Health of Navarra in Spain.
Hello, good morning, everybody. And it is a pleasure to be here with you.
Yes, I can hear you very clearly, but somehow I do not see you.
Okay.
Hello, can you hear to me right now?
Yes,
Yes.
Rachel's gonna put you on.
Apologies.
Okay,
perfect. No, thank you, Rachel. And also we have Tilly, member of the European Parliament, that you could also add, Rachel. Thank you so much. Sorry, Caroline, go ahead.
Okay, perfect. Hello, Tilly. Nice to see you.
Hello.
Okay, Carlos, to start with you. In your region, perhaps you can already highlight some of the good practices that are taking place in your region on universal health coverage.
Okay, well, many thanks, first of all, to be able to share with you this, this is a small part of the morning. And sorry also, because as Luca was sharing with you, unfortunately, I have to leave in 20 minutes. But I would like to highlight a couple of questions from our experience here in Navarra. The first is that in 2013, here in Navarra, it was approved a law recognizing the health universal coverage for everybody without, taking into account from a right to health perspective and approach. It was, let's say, a very advanced and innovative legislative piece at that time. I am talking about 2013. But unfortunately, the national government injured this law. And 5 years later, in April 18, the law was rejected by the Constitutional Tribunal here in Spain. Why I am expressing that at this moment? Because, and after that, we have developed, like in the other autonomous communities and regions in Spain, legal basis to be able to cover everybody in our regions. But in my understanding, it's important to underline that we have not a legal frame, global legal frame in Spain that cover absolutely everybody. Still, most of the person and the people, including migrant people and so on, are included de facto, but legally talking, still we have some problems with people, irregular people, people without papers, and so on. This is important. In our case, after that, in fact, we have developed in Navarra a couple of decree, which is the level of the regional level, let's say, giving the right, the coverage, the health coverage to almost everybody, with two exceptions, which are students from other countries studying in Navarra, for instance, in the private University of Navarra, which, and the second is rich people that have the right to establish and to be to have residence in Spain. There is a law in all Spain recognizing the right to establish here if you invest, let's say, I think it's more than 1 million, 1.5 million euro, something like this. Is very exceptional group of people, by the way, people from Russia, for instance, and so on. But this is, we are talking about few people. So, in fact, right now, at least in Navarra, and I would say that in all regions in Spain, the universal or almost universal coverage is guaranteed, but not legally talking, de facto. This is my first comment. The second comment related to good practices is that we have put in place one table, including led by our regional authorities, migrant authorities, and we participate as the health service from our side, and also the NGOs are included. NGOs like MDM, first of all, and also Caritas and the Red Cross. In that table, we meet regularly and we monitor what is going on in terms of problems, barriers to access, administrative barriers. This is possible to be done rather well in Navarra, because we are talking about a very small region, only about 640,000 inhabitants. So this is possible to be monitored in a very, let's say, accurate way in this small region. But in other realities, as a countries and so on, is much more difficult if legally is not clearly established the right to health. So in practice, this table, in my opinion, is a good practice, because we were talking about good practices in regions in Europe, because we, in common with the organizations that are working with migrant people and vulnerable people, we are monitoring in practice what is going on. Because although they can here be access to all healthcare, basic healthcare, like exactly the same like the rest of citizens, is the same amount, let's say, of care in the same conditions. But for instance, we have one administrative problem that in some cases, the persons and people, they are receiving the invoice for the care and the hospital care or primary health care and so on. So social services at the health centers have to intervene and then delay the invoice. And of course, at the end of the day, the people do not pay. But for the time being, is a barrier in the sense that the people, when they receive one invoice, obviously is not so, is a problem, no, for the people. So these were a couple of points that I wanted to share with you. One, the importance of the global legal frame, which in our case was approved, this law that I mentioned, but unfortunately is not operational right now because was rejected by the Constitutional Tribunal. And the second point is this sort of good practice in the sense that as legally we have still some administrative barriers for some people. We are talking about which people, for instance, has not clearly recognized the right. The main group in our case is the people, not the migrant people, not the irregular migrant, for instance. They have the right to access, but fathers fathers of the people working here, I am talking right now about irregular migrants, parents coming here and they don't have the right, the access to healthcare. It's not a big amount of people, it's not a big group, but still is a problem. And that's why we are monitoring the situation as close as possible with the NGOs and the people involved.
Okay, thanks a lot, Carlos, for your intervention. And it's really odd to hear that indeed your suggested law was not accepted nationally. But good to hear that you have set up exchange mechanisms with civil society and NGOs to see how we can improve the situation. We will get back to you later on after all the panelists have spoken. But for now, I would like to thank you for telling and sharing your experience from the regional level. And now I would like to go from regional level to European Union level. And I am delighted to present to you Rita Baten. She's a senior policy advisor at the Social European Observatory. So Rita, so what can the European Union do? And is there let's say, a consistent approach at the European Union towards universal health coverage?
Thank you, Caroline. Thank you, the organizers, for inviting me, and congratulations with the report, which has really highly relevant data also for discussions at European level, I think. When we talk about the EU and healthcare, usually it's assumed that the EU, and rightly so, does not have powers on healthcare. Healthcare, the organization and the financing is competence of the member states, and Europe only can support and coordinate national healthcare systems. However, what we see is that Europe is increasingly dealing with national healthcare policies and also with issues related to access to healthcare, but not through the direct powers Europe has on health policy, but indirectly through other powers that Europe has. And it started basically with the powers on macroeconomic coordination of national policies. And then there was a layer added on social policies, and which included access to healthcare. And the main vehicle through which Europe is dealing with national health systems and reforms in national health systems is the European semester. The semester is a mechanism, an annual mechanism for coordinating macroeconomic and social policies within the member states. And it starts with Europe providing an overall guidance on what are the main priorities and the main principles for national structural reforms and policies, financial policies as well. Then member states have to draft national action plans, which then are monitored at European level. And healthcare is increasingly incorporated in this process. Initially, it was in the wake of the economic and the financial crisis, 2008, 2011. And the first focus was on cost containment, on public expenditure in the healthcare sector in the wake of the financial crisis. But gradually, in the years after, much more attention has been paid to access to healthcare, also because the European actors were aware that measures that had been taken in the wake of the financial crisis were destroying access to healthcare in some countries. So there has been really an important reduction, or access to healthcare has been harmed in some of the member states, in particular the ones that had the most important financial problems, such as Greece, Spain, and some others. So there came more attention to access to healthcare, and the European Pillar of Social Rights is a result of this reflection to have a counterbalance against the purely financial public expenditure approach of EU guidance for national health policies. And the European Pillar then gave a counterbalance, not just for healthcare, but for social policies. And then what we have seen now with the pandemic and the COVID crisis is that there are important EU funding has become available for structural reforms in the member states to deal with the consequences of the crisis, but also to address long-standing challenges in member states. And also in these new financial means through the Recovery and Resilience Facility, healthcare is one of the strands for which the EU funding can be used. And all these different elements, so the macroeconomic supervision of national healthcare policies, the European Pillar of Social Rights with ensuring access to high quality healthcare, and the funding through the Recovery and Resilience Facilities, all have been incorporated in the European semester. So now there is more than ever a potential to steer reforms in healthcare systems through European instruments and tools that have been created. And access is on the table there. However, there is who is not on the table, well, who is on the table, but no, who is on the dish, but not at the table, are the health ministers. Because health ministers don't want Europe to deal with healthcare. So these policies are developed by other actors and by other policy makers that are not responsible at national level for healthcare policies. And that is a problem. And that also makes that the discussion on what should be the objectives of national healthcare systems, being providing high quality care to the whole population, that it is not the core of the discussion. And so this makes that there is certainly room for pushing more of having, well, first, those actors that are responsible for providing access to healthcare on the table. And secondly, to have a robust global vision on how should Europe deal with national health reforms within the European Union. Thank you.
Thanks a lot, Rita. Maybe a quick follow-up action. I mean, you highlighted the potential indeed from all of these structures, but from your point of view, do you see there's any sort of evidence that this has indeed steered reform in member states, or this has indeed pushed member states to improve the way they organize healthcare, and particularly of the topic of today, towards undocumented migrants or homeless people? Or, I mean, how do the member states, how do they differentiate between these people? And yeah, have you seen any impact of those instruments?
Yeah, well, first, it's very difficult to measure what is the impact of EU guidance and what is the impact of national priorities in health reforms, and what is driven by national motivations to reform the health system. Secondly, well, I did not do a specific assessment on the impact of the guidance at this moment. I did it after the crisis of 2008-2013. But the financing instruments that are available now, they potentially have more impact in the less developed, economically less developed countries of the European Union than in the more developed, because the approach to selecting projects to fund in, let's just say, the EU 15, the Western European countries, is much more focused, for instance, on e-health, and much less so on access to healthcare, which is a pity, in particular for the groups we are discussing today, because the problems are huge also in the Western European countries. So the impact may be more important in Eastern European countries and in Southern European countries. And there is a focus in some countries also based on EU guidance, and in particular through the European the cohesion funds, towards ethnic minorities and, for instance, the Roma in some countries. So yes, in some countries there is certainly a progress with regard to access to healthcare, or support for progressing on these issues, but much less so in the Western European countries than in the Eastern European countries.
Yes, I see that. Thanks a lot, Rita, for your valuable insights in this. Let's now move on to our third panelist of this morning, Ewout van Ginneken. You are working for the European Observatory on Health Systems and Policies, and you are also coordinator of the Berlin Hub. Yes, how can we compare European health coverage across the different countries as such diverse health systems in the different countries? So how do we measure this? And yes, I was wondering how you approach this.
Well, thank you, and also thank you for inviting me to this important meeting. And I do really welcome, the report, and I agree that we need to put this front and center and make this really important in the next years. And I think I'll get back to that later. But to your question, one of the things we do, we write reports about health systems all over Europe, the geographical Europe, WHO region Europe. And we do include questions also where we ask the authors to discuss, access to health, and also access, for example, for migrant groups or et cetera, et cetera. But it's really difficult because the situation between countries is still quite poor, I think. The data isn't there. So I think data is the point that we discussed also in the previous session today, is a key issue here. Some countries have statistical agencies that are probably understaffed, cannot provide this data, may not have the political or not allowed sort of to look into the data of undocumented migrants or Roma. So there's also a level of that. So it's very hard for the people we work with to give a good description in the absence of such data. And then obviously you can look at smaller research done in the field, which is more about a certain area or a city. This is also where your work is incredibly important for Médecins du Monde, but only for those countries where we have it, that we can refer to it. So clearly, this is a huge problem. And because it does show, and we've been trying to say this as well, that we do have, although we like to think that we are very good in Europe in terms of universal health coverage, and probably we are better than many other countries, we still have huge problems, and it's not just limited to population coverage and certain vulnerable groups not having coverage at all, but it's also the coverage of benefits and also financial coverage for people. So some people will have huge problems, and some of the instruments that we have available, comparable data available, like unmet need, may not always be that helpful explaining who exactly these people are. And some of these problems are hidden under averages that look quite good. So we need to have more refined, more granular, I think, data. And I agree totally with also what Rita was saying. There is also really an interest, I think, from the European Commission, and they've been also working on more granular data, and we've been helping as well in that field, looking at, using a patient vignette and seeing how a specific patient has access to healthcare. But I think we need a renewed focus, really, also on population coverage of those vulnerable groups that we're discussing here today, mostly.
Yes, thanks, Ewout, for this. Then I was wondering, why is it not possible to include other kind of methodologies like qualitative methodologies? I mean, in terms of having a focus group, interviews, or other ways of revealing often the information that's behind the hardcore statistics, no? So the reasons why people struggle, the barriers that they meet. I mean, does not always need to be quantitative data that can be used to enrich the reports, these mainstream flagship reports I mentioned from the WHO and from the Commission. Can that not be included better?
I think it can, and it's in some cases, I think, if you, for example, work with general health system researchers, they may not be too familiar. So we need to also help them and also link them up with some of the organizations here. Do you have more information about the situation on the ground? But apart from that, I do think that there is power in numbers, just to have those real numbers, the real size, the magnitude of the challenge across the different countries. And for that, I think we need, some kind of European funded project, maybe a Horizon project, where the Observatory, WHO, IOM, Médecins du Monde, PICM, FIANSA, they're all involved, and we look at these countries, and not just a few or a sample, but all of them, and come with specific recommendations how data collection can be improved, but also working with statistical agencies, because it happened a few times to us already that we come with recommendations and then later we hear, well, it's impossible to implement. Well, I would like to know why it isn't possible to implement. We want you on board. We need to talk to those people who are responsible for that, data collection. Of course, I agree with you. The power of qualitative research, and we need to use it, obviously, but I think we need that basics, good data about countries so that we also can compare. And then I think we have something incredibly powerful for policymakers, and I think that's also something that policymakers want to have from us, and then hopefully really change the situation, because I think it's going to be key, especially now after the pandemic.
Yes, and thanks indeed for this call for such large new sort of projects. It can be a joint action under the EU for Health program, or maybe indeed Horizon Europe program. This is definitely important for us to suggest. Maybe one more question to you. So, from the work that you've been doing at Observatory, so how far are we from universal health coverage in Europe? Just very briefly.
Yeah, I said it, I'll keep it brief. We are not as far as we like to think. That is my short answer. And we know that because, yeah, we're doing different kinds of research. We're looking, of course, very qualitatively at what countries are doing. What we hear, there are still groups of people who suffer. And I think we need to do a much better job and not equating, you know, a formal entitlement to coverage with actually accessing coverage. There's a huge discrepancy between the two that we need to address much better.
Thanks, Ewout. And just I would like to quickly go back to Carlos, because I believe, Carlos, that you have to leave us too soon for a parliamentary meeting. Maybe one final question to you. So what are your sort of lessons learned, or your, from since the pandemic and now regarding access to healthcare for all and covering those that experience unmet need?
Well, this pandemic, I would say every pandemic has a sort of social bias. And in our case, we have experienced special, let's say, challenges with vulnerable people, migrant people, vulnerable people in general, that they didn't have the conditions, for instance, to be able to isolate themselves when it was necessary. Also, the testing of people, for instance, temporary workers, being here in the region only for a short periods of time. So we have tried to monitor rather closely the needs, especially, let's say, needs of these persons, these people, and in agreement with the social services from our side, the health services, and also the 2-3 NGOs, organizations working particularly with them. We have put in place some interventions very specifically focused on that. For instance, we had during the whole pandemics special households free for people needing you know, this sort of conditions for isolation, because they were living in massive, let's say, compounds, and then offer them the possibility to be for the period of isolation with these people. And also, well, we don't have time right now, but you know, in our experience, and I would be very happy to be able to share with you if needed, you know, the written experience from that, let's say, social, we call in Spanish la pata social, the social, let's say, bias of this pandemic, which has been very, very important, because of course the people in vulnerable situations were in a special, let's say, risk for one side, and also need of some special, specific care for that situations.
Thanks for that, and also thanks for highlighting the cooperation between the health services and the social services, which is so important, as we've heard also in the first panel, as often people have complex needs which needs to be addressed holistically. So thanks for sharing your practices, and thank you for participating in this event.
Pleasure, many thanks.
Okay, right, let's now go to Tilly Metz. You're an MEP, a member of the European Parliament, in particular of the Committee on Environment, Public Health and Food Safety. And we are delighted to have you with us. And maybe you can say a few words about the role of the European Parliament in all this, and how you see that NGOs and organizations like PICUM and FIANZA and Médecins du Monde can help you in ensuring equal access to healthcare for all.
Thank you very much for having me. And first of all, sorry that I had to stand up a few times and could not be there from the beginning on, as we have in parallel our political group meeting and with votes. So it was a little bit hectic. Sorry for that. But I'm very happy to be with you, especially as I know the work of Médecins du Monde. And if I may say so, I'm very fan of what they are doing. They are doing a great work. So let me say that first before going into your question. So what can the NGOs do? What can also civil society do, the different stakeholders, especially for us Greens? I'm always in every file defending, as I was working also on the initiative report on the pharma strategy, and and also on the MMA data, etc., that we involve really in the decision making process, also that we have representative of healthcare professionals, of patients, of people that are directly on the ground also, and that their advice is taken seriously. I must say personally, I regularly meet also with society organizations and NGOs to have their precious input for my files, because it's very important to really hear from the ground, not only, if I may say so, in our Brussels bubble, but to really hear from the ground what are the needs, what are the demands, really, in order that we can also on European level really foster this universal coverage on healthcare. So what we did, for example, in the EMA mandate is really to have those experts group and to make also the whole process more transparent. I think transparency is another very important point. So also in order to guarantee the absence of conflict of interest. So also in the BICA report, so Europe Speaks Cancer report, we also try, it was crucial to have the input of the civil society, of the NGOs. But I could also say there is, of course, the possibility for the citizens, for the NGOs to start a European citizens initiative, you know, a European petition. And I think a lot of people are not aware of this possibility really to make change move, to make them go into the more right direction in order to guarantee those health care for everybody. I think the pandemic now really showed the weaknesses of the system, also of the national healthcare system. And you mentioned it, and it was already mentioned before, that really more vulnerable people were really left behind, and also with their access to regular care during the pandemic. So that's something we have. There are a lot of lessons learned out of this pandemic, because it only emphasizes the weaknesses of the healthcare system that we have. So if I may say so, what you can do else is, of course, and I'm happy I had just also a little chat on the side. I'm also happy, of course, people should go to the member of the European parliaments of their countries and ask them, accountability. What are you doing? Because also the pandemic is showing that we need more competences at the European level to tackle global crisis, of course, and that we need also to do more there. I'm now taking an example in order to guarantee better access to medication, but also to vaccine, is of course tackling the TRIPS waiver, so the intellectual property rights system. And it was also already said we should definitely make out of the pillar of social rights, it has to be declined now in legislation, in directive, to make it mandatory. Right now, the pillar of social rights is more a lot of them, they're starting now to decline it in directive. But at the beginning, the pillar of social rights was very nice to have, but it was not mandatory. So, and there you mentioned the Article 16, I think was already mentioned, of the European pillar of social right, that everyone has the right to get timely access to affordable, preventive and curative healthcare of good quality. So this has to become really reality, and therefore we have to decline it into really legislative text. So that's another very important point. But just let me make, if you allow me, to make a general point. At the European level, I think, and that was also shown now through the purchase, for example, of the vaccine, we need really a paradigm shift in our functioning of the healthcare system in the EU, putting really the health of the citizens in the middle of our concerns and not commercial interests. So, for example, for me, medication and vaccination should be considered as common goods and not commercial ones. So, which then make a very small minority very rich. So, our job, and then we need to do a paradigm shift at the level of the institutions. And also, let's be honest, the European Commission was not used doing advanced purchase agreement or purchase agreement with private companies. So, okay, that this was new, and we need also their full transparency regarding the contracts, and also where the public money did go. And in order, therefore, and not only protecting commercial interests there, it's about an overriding public interest here when we speak about health, and that we should put in the center. And there, the European Union has a lot of tradition regarding trade, but now we have, for me, really to do this paradigm shift and put the interests of the citizens, and I mean there all the citizens, of course, in the middle of our interest.
Thank you for this, Tilly. We've heard from Rita about the European semester, and you spoke about the European pillar of social rights. So these are important tools indeed for universal health coverage. What is your view on the European Health Union, which is mentioned by Ursula von der Leyen? We've seen it with the new agency in preparedness, the HERA and the EMA, and the mandate for the ECDC. In my view, the European Health Union is very biomedical, and does not sufficiently take all of the social and mental health issues and so on into account, let alone the topics that we are discussing today. But how is your view on the European Health Union, and is that a potential tool to further use for our advocacy to see it more broader, or what is your advice to us on this one?
Yeah, but the European Health Union is very often mentioned by Ursula von der Leyen, by the president. But now we have to make it really also a reality, not only nice words and nice wishes, but we have to make it a concrete roadmap how we achieve that. I think there are a lot of files coming up regarding health. I mentioned there is really this pharma package that is going to come about pediatric and orphan drugs. There is the blood directive revision. There is the health data space that is coming. So there are really quite some files in the loop that are coming up now, and which should definitely always aim at tackling medicine shortages, guaranteeing accessibility to treatment in the member states, because also there are big differences, as we said already, in the member states, but also between the member states. So there is, but you're completely right. It's a lot focusing on the biomedicinal aspects, and we now have also to consider, of course, all the social impacts. And also now I'm submitting with other MEP colleagues, we are submitting a pilot project into the Environment and Health Committee regarding very low threshold help on the level of mental health. So really low threshold help that we need to install to be really there where the people are in the streets and to offer them this low threshold help. So there we are doing a pilot project. It's, of course, you might say, okay, you're doing a pilot project and then, but it's the first step really to raise awareness that we should do more. They're also sharing good practices at the European level, and especially you mentioned mental health. I think not only during the pandemic, it showed the vulnerability of a lot of people, but especially those who are already in very difficult situation, that we definitely have to do more there. But I think also that the European Union is now much better prepared also to have more competences at the health level. But as you know, there are three big instances that decides, and it was mentioned already, it's also on the member states level, on the ministers' health level, to agree really to say, okay, we are stronger to fight sanitary crisis, to fight poverty, etc., if we are acting together and have a coherent and a more coordinated approach. So I think really at the European Parliament level, a lot of people are really aiming at giving more competences to the European Union, also to better coordinate research, etc., to have a better exchange of practices, as I said already. But now the health ministers have also to go into this direction. I'm lucky, I'm from Luxembourg, and the minister from health minister of Luxembourg very clearly said that she was happy during the pandemic that there was this strong cooperation, for example, for purchasing vaccines at the European level. She very clearly said we would not have had, and it is completely true, so quickly this vaccination, etc., for all the people if there would not have been action at the European level and also investment at the European level.
Thanks a lot, Tilly, for your great work that you're doing in the Parliament, and thanks for your intervention. Michelle has given me 10 more minutes. This is important because we are running a little bit out of time. So my idea is to give the floor to Santino, and after that, I'll go back once more to all of you with one final question. Yes, so last but not least, Santino Civroni, you are the director of the Migration Health Program at the WHO. And yes, we are delighted to hear from you. And maybe my first question is referring to the Global Compact of Migration. We've heard already from Michelle from PICUM, she referred to this. So how can we make sure that we better bridge and measure also these global commitments and into real action?
Yeah, thank you. And thank you for having me with you today, Caroline and colleagues. Well, I would like to address this question by starting with the fact that if we are observing the global and regional and local landscape, probably never before we had such a level of richness of policy, framework, strategies, principles, and clarity of what needs to be done. So a lot of progress has been happening in the last decade in this regard. And the Global Compact somehow reflecting those progresses. If you imagine the Global Compact didn't start is not a health paper. And the most common approach or feeling in relation to migration and health in the past was that health was a side effect of the migratory process. While the situation has been radically changing, partially also due to the recent crisis like COVID, where health is now perceived as a founding principle for the management of the migration process. Now, what needs to be done to measure? Well, together with all those positive elements and progresses, there are also some caveats which still need to be addressed and need to be resolved. For instance, the compact born without indicators. So now the caveat is to be solved utilizing SDG-based indicators to monitor progresses in implementation of the Global Compact. The SDG, they were really a revolution because MDG was not almost talking about migration. SDG has at least 5 specific SDG focusing on migration. But there are probably 34, something like 34 indicators related to measure progresses of the SDG in terms of migration. But when we go to health and migration, the only indicators available are related to SDG 3. So at the end of the day, we have proxy indicators. So again, there is a bit of need of a bit more efforts to make sure that we start to collect those data on routine basis. Then when we go down to the regional and country level, particularly at country level, some of the issue came up during the discussion previously, but also I think the report launched today is a fantastic mirroring of the situation, particularly in my view, because it's looking into the situation with operational research in countries which are usually considered champion countries in terms of managing migration. So that is really taking the picture of what is functioning, what not, in terms really of mechanic on the ground. So the impediment to really measure progresses are mostly still related to a very fragmented capacity or effort of the member states to strengthen their own national health information system. You need to consider, for example, within the EU countries, the collection of data disaggregated by ethnic status is not allowed by constitutional framework in certain countries. So the issue of routinely collecting data against precise indicators is not yet there. The second point is related to the necessity to continue to to make pressure on the action of depoliticizing the topic. Particularly in the high-income countries, the provision of health services is decentralized. And this is an additional level of complexity in when we are trying to secure a coordinated or uniform approach. And the political sensitiveness still play an important role in somehow influencing the priority of action of politicians, and then as a consequence of the health system managers or who decide in the health system. An example, we were monitoring the situation during COVID, and it was interesting to see that despite a lot of countries, particularly in Europe, but not only, have been showing commitment to adopt a universal healthcare approach in terms of non-excluding migrants, regular, irregular, and refugees in accessing the preventive and curative element related to COVID pandemic, majority of the country did as a temporary measures by waiving the existing legal frameworks in order to allow COVID-19 response for the time being, but not necessarily triggering a structural change. What you have seen in the previous presentation, which I really enjoyed to read the report, and also the presentation of Rachel, that slides with roofless, homeless, so different categorization of the most vulnerable in reality we are dealing in our society, was also the reality in access to vaccines during COVID. So the reason mostly was not for a political obstacle or lack of commitment or capacity of the health system, but because the system in place was not taught to include those people. So how those things have been addressed by mobile immunization clinics or vans, so ad hoc measures. Are those measures triggering reflection and discussion for an institutional change? Not yet. And those are the obstacles really giving big problem in measuring progresses, but also delaying progresses in inclusion of this part of population particularly in need. If we look at the low and medium and low income countries, then the situation is really hampered by an issue of capacity, by an issue of availability of resources. In fact, the Global Compact brought in 2018 a very interesting concept, shared responsibility. So countries which are in difficulty are supposed to be supported by the international community, and also through a mechanism of inter-regional, inter-country cooperation. This is not yet there. It's very poor. We have seen also, again, once more in access to vaccines during COVID, how the access to vaccine was really speeding up in the high-income countries and lacking behind in the low-income countries.
Thank you, Santina, also by referring to the SDGs again, and to use that as a tool for measurement. And you raised the issue of political sensitivity, which is indeed a continuous challenge, and ways to deal with barriers. You mentioned the mobile vaccination services, and I think early on in the chat during the first panel, I think Lucinda Hian mentioned also digital barriers that people have that need to overcome. You mentioned the low-income countries, but I was wondering, are there other parts of the world that we can learn from in terms of universal health coverage, as you have this global perspective? So what are the lessons elsewhere that we can use here in Europe to improve our systems?
Indeed, there are a number of interesting experiences present in different parts of the world. I'm thinking about Latin America, Central America, Thailand, where really the concern of inclusion to have a universalistic approach has been translated into day-to-day actions and routine actions of the health sector. In reality, I like to reply to you, Caroline, a little bit flipping around the question. I would like to say what EU can do for the world. When I'm looking to the EU region, this is a region which has been developing based on the most important human principles and universalistic rights. What we lack on health and migration, it's really a consistent global leadership and leading by example. That's what is needed. Leading by example is probably the most powerful way to diffuse concerns, political manipulation, political polarization, and also this would need to be supported very thoughtful technical assistance, operational research, because what we have seen during COVID, universal coverage is possible. And those countries which adopted a universalistic type of approach really went to bankrupt, which is usually the most common argument in the health sector when we are talking about inclusion of particularly those in irregular situation or those in the most vulnerable situation. So indeed, there are interesting experiences. We are not very good yet, everybody, even WHO, in really building channel for inter-regional, inter-country exchange of experiences. I was in Istanbul and we really invested in it. That was beside that was organized by WHO, but really a very important event because we tried to launch those bridges of collaboration. European Union does this since a number of years with a program for Africa, but more need to be done also from the practical point of view to address practicalities and problem solving at the origin of the migratory process, and to probably flip also the politics, the policy of managing migration. Now, still the most common approach is towards border management, and this is creating bottlenecks. This is creating difficulty to manage the migration process. Probably the approach of inclusion we see now with Ukraine refugees, it's the most powerful and effective way to manage movement of population, forced or not forced.
Excellent, Santino. Thanks a lot for sharing your views and indeed to call upon the EU to take on more this global leadership, which is an important message. I had wanted to do one more round to give all of you one last key message, like your priority on this issue, but I'm struggling here in terms of time. So I would like to let Michelle decide how to move on, because I know there may be some questions in the chat that I wasn't able to follow. And I think that François de Kersmaker was supposed to take over from me. So
exactly, Karen. Thank you so much for your work. It's quite difficult to struggle with time, of course, when it's so interesting and so many interesting contributions. But indeed, we would like not to finish too late after 12:30, and also to give the chance to 2 or 3 questions to be sent to the panelists. So I'll leave the word to Valentine, who is our advocacy officer at the MDM network level. And I get it's picked up 2 or 3 questions, sorry, no more. In order not to finish too late. Thank you so much again, Caroline, for your good moderation. Valentin.
Yes, thank you very much, all of you, also for the interesting questions in the chat. So I tried to select out to highlight the most relevant ones and the ones really addressed to the panelists. So the first one I found is from Johanna from MDM Germany. It's a direct question to Rita, and it's about the European semester. And this European semester is apparently based on the EU Silk also, which only includes, well, people with private households. So we meet here the same issue as also addressed. So is there a plan to change this in any way and to include, well, the excluded population and to have these indicators perhaps changed? Do you know anything about any plans?
Yeah. Well, first, I don't know of any plans to change this, and I think this has also been the main focus of a previous seminar of Médecins du Monde on this issue. And I think we discussed here already a bit that I guess it's mainly a methodological issue, that it is very hard to get reliable data on the groups that Médecins du Monde is working with, because these are survey data, and so you have to have a representative number of people that you can question, and for the groups that are left out, it's much more difficult to have reliable data on. So yeah, there's an important need to reflect on how to include these groups, and I think the report today shows some elements, but I don't have the real answer to that. And I don't think there is a reflection at this moment at European level to change this, and that would be good. And maybe the suggestion from Ewout to have a European data project would be a good step to start collecting data on who is covered and on unmet needs for other groups that are not in the EU Silk data currently. Thank you.
Thank you, Rita. Then another question, it was mostly based, it was commented for panel 1. It's from Frodo Ike. As primary care is the main need of these populations, and different NGO clinics reach people who other don't, how could we work to improve the partnership between NGO clinics and people health care as an integrated primary care? So maybe, well, if someone of panel 1 would like to intervene on this question or on this remark, what do you think?
Plus, maybe?
Yes, thank you. I'm sure there are more than me that would like to contribute, but my short answer is that in MDM Sweden, we have worked hard not to take over the work of the regular health care. So I think cooperation is important, but we are not interested in doing the job of the regular healthcare system. We want to be there as a sort of safety net for those who fall through, but we will try to change the actual structure of the regular healthcare system so it will take care of our patients. Our goal is to sort of not be needed anymore.
Thank you. Thank you. And then a last question to wrap up the Q&A session. It has been mentioned several times that there are also digital barriers to healthcare. So what do you think is this kind of digital barriers? Are they getting more and more important, in taking into account that digitalization in medicines and health systems in general is getting more and more important too? So it's kind of an open one, but please perhaps one of the panelists who would like to contribute can do so. Feel free to speak up.
I can say something, Valentin.
Yes, please.
We've seen under COVID-19 pandemic an incredible proliferation of all kinds of uses of remote healthcare, telemedicine, you name it. And the big risk is indeed exactly what you say, and that's why this is something that we need to focus on. All of us, that vulnerable people will suffer. These instruments also have the risk that they increase inequality, which I think is the main challenge going forward after the pandemic. Also, the point I just made in the chat here.
Thank you, Evert. So that's about the questions I captured in the chat, and I leave it to you, Michel.
Tilly and Santino wants to add something?
Sorry.
Yeah, just thank you. Very, very short. Just a tweet to complement the question on digital health. Indeed, very important. But in my view, we need to pay even more attention. We were talking about health and migration to governance of data and repository of data, because this has a very important legal, not only ethical implications.
And Tilly wanted to add something also. Tilly?
No, I was just saying I'm very happy about the question, because a lot of people think now everybody has access to digital, to computers, and also regarding, for example, just to take an appointment for vaccination, often it went to a digital platform. So it is very important in all the issues regarding healthcare that we do not forget about all the people who don't have iPhones, who don't even can afford one, and not speaking about affording an abonnement. I don't find my words anymore. You know what I mean? Because there you have to pay, you have to be registered, etc. And also in a lot of rural part, and it's not only about elderly people, but you mentioned them all already this morning, also about refugees, etc. And other people who don't have those access, who are not connected the way we are. So I think it's a very important point. And just let me mention, as you might see or know, I'm in the Green Party, and there is a lot of movement also regarding medication, that you don't have any explanation paper to the medication anymore. And even though I'm in the Green Party, I said, no, I don't want that people always have to look at the internet, and because a lot of people just don't have this access. So we need also still a paper information to also get these people have access to the right information. So I think that's really important to tackle, and to be very also giving the possibilities also, of course, of digital training throughout your life. And that's, we have also good example in Luxembourg, it's digital inclusion, because it's very important that we don't leave anybody behind, but be realistic that some people are just not connected all the time. Sorry for having been a bit too long, sorry.
Okay, now thank you so much, Tilly. Well, we know it's such an exciting and interesting and important debate, but unfortunately we have to wrap it up here. And I leave the floor to my colleague and Belgian fellow, François de Keersmaker, who is head of Artsen der Welt, Doctors of the World, Germany. François, floor is yours.
Yes, thank you very much. And I certainly don't want to keep your time anymore. I think this this webinar is super impressive. First, because of the number of people who have been following us. We had up to 135 people. That's at least what I observed. This is also the wide range of competencies we have here. Also very impressive, and also evidently the quality of the panels, the panelists we had. That's super interesting. I think we have a lot, so we go back to our jobs with many ideas, many big stimulation for further action, but especially very concrete ideas and options to continue the work. And I think our main focus was on making evidence, making the invisible visible, the unheard heard. And I think this continues to be the big challenge, because even if we are here among us, people who are dealing with the unheard and the unseen people, the message has to go out from this circle. It's already impressive to see that the circle is very wide, and yes, having people from different, very different horizons and fields of operations. But still, I would say we are here a little bit among us. Yes, a group of informed people, interested people. So how to get the message out? And this is I think this is the remaining challenge. At the same time, many people talked about momentum. So I think the number of people being here is also a symbol of this momentum. We had a lot of examples of initiatives that are producing results, that are having impact. And somebody was talking about patience, persistence, endurance. This would be also one of my main messages, to say we have to keep the energy. It's bringing something, as we saw from various examples. Especially, I remember from Michel, who was talking about many initiatives that have been successful. I think also that one thing I noted is that we lack the bridge into the national legislations. Even if we have a lot of initiatives and instruments at the European level, still we miss the link with the health ministries. This was one of someone said that, and I found it a really good remark, because this is a call for action for all of us, how to sensitize our ministries of health in the single countries, because they are the people who will implement or who will change the laws as we think we have to. And my maybe last message would be also the last thing I picked up from the whole discussions is that we have to continue to work as civil society, even if the ultimate goal is that the official system is working and not exclusive anymore. Still, there will always have been gaps. The formal systems are never covering all the informal things we are observing, and that's our role as civil society organizations, but also as researcher and scientific community, to keep an eye and to keep our role as making evidence and making things visible, so that the policies can be constantly adapted. We will continue to have a role. I share the vision that we should be unused, how do you say that, useless as soon as possible, but I guess this will not be the case, because there are always gaps, and the reality is always more complex than the formal system that we can invent for filling the gaps. So our role will continue, and we want to hand in hand with the civil society and the researchers to make this evidence, and use all the people who were here today and have the good connections with the politics to make this a reality in the future. Thank you very much also, especially to the organizers of this meeting. It's a great panel. You made a super job in gathering all those important and competent people to discuss with us and to give us all those inspirations. And also a big thank you to our translators. And with those thanking words, I would stop here. Thank you.
Thank you, Francois. Thank you to everybody. Thank you to all panelists. And we have a last video for you to show, so that we can say goodbye in a very soft way. And we, of course, will see you within 2 years for the next report. Thank you so much, friends, and we keep in touch for sure for this very and common strike together. Bye-bye. Then we launch the video. See you guys. Thank you so much. Bye-bye.
Bye.
Bye.
Même la mer du Sénégal, on l'a vendue. Tu ne peux pas pêcher. Les pirogues sont garées au Sénégal. Parce qu'on ne voit pas les poissons qu'on va pêcher. Comment on doit faire? On va chercher autre chose. On entend Espagne. Habiter la rue, ce n'est pas une solution. Mais c'est situation obligée. Rester à la rue et dormir à la rue. Mais c'est dur. La rue est dure. Il est froid. Aujourd'hui, on n'est pas cuisiné. On n'a pas quoi manger. Nous tous, nous sommes restés comme ça. Une personne ça qui va donner 1 euro ou 2 euros pour acheter du riz avec poulet pour cuisiner. C'est là qu'on a resté seul. J'ai ressenti mal. J'ai blessé. J'ai parti à l'hôpital pour soigner. Et j'ai demandé au docteur, j'ai venu 2 fois, je le demande, j'ai dit, j'ai blessé sur la pied, mais je peux pour me soigner. Il m'a dit non, il faut que tu amènes ton papier. J'ai dit non, j'ai pas mon papier. Peut-être moi aussi, j'ai dit que peut-être c'est la loi qu'il veut. J'ai retourné, j'ai parti l'autre jour aussi, il me dit la même chose. Après, j'ai quitté là-bas et j'ai venu ici. Passe-moi mon pied par moi seul, chaque jour. Prends un masque et je le attache dans le pied. Parce que je n'ai pas le moyen pour le bandage là.
Bueno, nuestras condiciones de vida también afectan a nuestra salud. Si no comemos bien, no dormimos bien, no estamos bien abrigados, pues nos sentimos peor. A esa persona es lo mismo. Si no los acogemos bien y no atendemos a sus necesidades básicas, no podemos mejorar su condición de salud. Si nos concentramos en alejarlos en sitios aislados de los servicios básicos, hacinados en un mismo lugar, eso no sana.
Well, thank you, everybody. See you guys. Bye-bye. Thank you so much. Bye-bye.
Many thanks.
Bye.
Bye.
Thanks.
Bravo, bravo.
Thank you. Fantastic job.
No.
Lecz estrega. Só preciso lá buscar o eu tinha prosseguido, mas também não encomendei, não sabia. Agora vou obviamente pensava em falar outras coisas. Não. Da saída está. Preparar-me para amanhã dar sábado. Eu também já não há. Não há. Tchau.
alguém que pôs o NIF 2 vezes e agora estão formando o duplicado. Sozinho, again.
Não acham que é outra coisa hoje?
Eu gosto, eu entendo, eu sou legal.
Cada maneira é pouco mais chocolate. Me esqueci na base. Tem um andar, tem cheio assim. Não.